Agora, eu gostaria de dar seguimento, convidando o Dr. Patrick Ott. Ele é médico oncologista, é diretor médico do Centro Oncológico da parte cutânea do Dana-Farber e médico professor adjunto da Harvard Med School.
So we'll go into systemic adjuvant therapies now. And I wanted to spend some time initially on the standard of care. Basically, this is my disclosures. And essentially talk about the drugs that are already approved in the United States, and I believe they're also approved in Brazil, right? So all of them actually. I thought it was a good exercise to go remind everybody about those seminal studies, point out some details, but then I also wanted to spend the second half of my talk discussing neoadjuvant therapy, which is not quite standard, but there's definitely interesting information emerging from initial trials. All right, and so ipilimumab was the first drug that was approved in the United States for adjuvant therapy. Frankly, we have actually never been really using it a lot, and I'm not sure whether you have, but it certainly, the reason why it was first was just because ipilimumab was obviously first in a metastatic setting, and that study out of Europe just was started a lot earlier, and we have a lot more mature data on the study. But I think what's nice to know about that study is that that we have this mature survival data, right? So at least like 5 to 6 years out, we know that ipilimumab itself can actually induce a survival benefit in patients with resected stage 3 melanoma. And I think if you want to look at the sort of the survivals on the right side, I believe you can see that there is something that could look like a plateau in the survival curve. But just to point out, so obviously we know that ipilimumab is more toxic than PD-1 inhibitors. I think certainly in the adjuvant setting that matters even more than any metastatic setting. And I think it's also, and we'll go into more detail on this, the toxicities actually can be severe and sometimes deadly, right? So even on this study, there were actually patients with myocarditis and Guillain-Barré syndrome, and about 30% of the patients had grade 3 or higher toxicity, which is a really high rate for healthy patients otherwise, right? So adjuvant setting. So moving on to really what we are using now and what's approved. This is the CheckMate 238 study, just to remind everybody how this was done. So it's actually, so it was testing nivolumab at the standard dose of, it was 3 milligram. Now we use, flat dose 240 milligram, but it was actually randomized against ipilimumab 10 milligram. There was actually at the time quite a bit of discussion whether that was a reasonable choice, because there were other studies that were ongoing that actually looked between 10 and 3 ipilimumab, the ECOG study, and we now have data from that. But basically, the idea was that the ipilimumab should be a real standard arm, and like Bristol Myers Squibb didn't want to sort of have an arm that was, or a comparator arm that would be considered potentially less effective than, say, like the 3 than the 10 milligrams. So if they had chosen 3 and the study hadn't been positive, people would have said, well, what about if you use, or the study had been, people would have criticized, like, well, what would have happened if he had used like the 10 milligram, right? So so they wanted to basically be sure that sort of the maximal active ipilimumab dose was used in that study. And sure enough, the data are positive. So there's clearly an impact on recurrence-free survival. The absolute difference is 13% at 18 months. And that's, I do think you see a clear survival benefit. Just want to, just point out here, so we are comparing nivolumab with an active treatment, right? So nivolumab versus ipilimumab. We actually don't have survival data yet on nivolumab. And I'm going to get into that a little bit later in more detail, sort of how the drugs compare. But just look at a couple of subset analyses, PD-L1 expression. I would actually say it's sort of all over the place, even in melanoma, where there, in some studies you see a difference, sometimes, or a real striking difference between PD-L1 positive and negative, and in others it doesn't seem to matter. In this study, the PD-L1 status does not seem to matter a lot. Also looking at, oops, I'm gonna sort this out here. And another one, like the BRAF status, in some study, particularly the ipi-nivo data, which I will actually talk about in my second talk in the afternoon, there's interesting data that BRAF mutated status could actually confer better, more benefit from ipilimumab and nivolumab. And so that doesn't seem to be the case with nivolumab only. So whether the BRAF status was positive or negative, the recurrence-free survival benefit was very similar between those groups. And also, I think it's another really important point to note that on this study, it actually included patients with stage 4 disease as well, right? So we have stage 3 and stage 4. And although when you look at the 12 months recurrence-free survival, it seems to be a little bit less with a stage 4. That's actually, when you look at the curves, they actually separate out pretty similarly. So that may be just a function of that 12 months landmark analysis. So the point here is it also really has an impact on patients that have stage 4 resected melanoma. And then there was a study with pembrolizumab versus placebo, which also showed a striking, clinically significant and statistically significant benefit. Also, no survival data available with this one. Hazard ratio 0.57. So pretty striking. Again, so this study is basically a PD-1 inhibitor versus placebo. Nivolumab is a PD-1 inhibitor versus ipi, an active drug. So I think that's definitely worthwhile to keep in mind, right? I've showed you first the ipilimumab data. There's like at least a 10% difference between ipi and placebo, ipilimumab and placebo. And so you kind of have to add those up if you really want to compare, sort of compare how would nivolumab versus pembrolizumab compare, right? Because in one study you compare with a placebo, and the other one you have an active drug. Here, just to point out that with a pembrolizumab, essentially all subgroups of patients benefited from the drug. So whether you look at thickness of the tumor, whether you look at just generic patient characteristics like age, lymph node involvement, ulceration status, all subgroups really were on that hazard ratio, had a pretty good hazard ratio compared to the placebo in that study. Okay, and you also mentioned ipilimumab, nivolumab in the metastatic setting. Of course, there's an interest to bring this in the adjuvant space as well. So there is a study that has actually been already completed, Checkmate 915, where initially there were actually 3 arms, and then now they completed a study with only 2 arms, essentially testing nivolumab at the standard dose, given every 2 weeks, 3 milligrams for a year. And then the ipi-nivo dose is not standard. So you can see that the ipilimumab is given 1 milligram every 6 weeks, also for a year. So it's really like a different regimen compared to what we have initially been using in the metastatic disease. The data, when the study was designed, actually came from the lung cancer literature, where it was actually relatively early on found out that if you give ipilimumab at a much lower dose and actually space out the treatment intervals, the toxicity is much lower. And it was just thought at the time of the design of the study that you could not give the standard ipi-3 nivolumab 1 milligram dose, which has toxicity 50 to 60% grade 3. That would just not be acceptable for the adjuvant setting. But we basically have no data yet from the study. It's a large study, as you can see, is like 1,000 patients in each arm. Okay, and then we have target therapy for BRAF mutant disease. And there's really the main study here is the COMBI-AD. Large phase 3 study, really remarkable separation of arms when you look at the recurrence-free survival here. They have this ridiculous like p-value, right, that people talk about. But it actually tells you a little bit like the p-value is not even, what one really need to look at is like the hazard ratio, right, which is like 0.47. The p-value is, it's nice that it's statistically significant, but there's essentially no doubt if you see curves separating out like this on a Kaplan-Meier curve. A couple of thoughts here. What I always thought, and it's certainly been discussed, was remarkable about the study. The treatment was given only for 12 months. And there's actually data from like the GIST literature where you use Gleevec in the adjuvant setting, and you use it for 1 year versus for 3 years or even longer. And the curves there seem to essentially come together once the treatment is completed. And so what I'm saying is, basically a patient would get like the treatment for a year, and then as soon as they come off the treatment, you would no longer see the effect of the drug, and you don't see anything like this here. So there's really not a drop off after a year when the treatments when the active targeted therapies are stopped, and there's this like really clear separation. And I think there's also certainly a fairly convincing evidence for plateauing out of the recurrence-free survival curve. And here we actually do have survival data as well. Curves don't separate quite as impressively, but there's certainly the hazard ratio is pretty sort of similar. It's not quite 0.5, it's 0.57. So also, in conclusion, the trametinib is certainly a very reasonable option for patients with a stage 3 disease. And I specifically point out stage 3 disease because that study actually did not look into stage 4 as opposed to the Checkmate 238 study. Okay, so if you have a patient with a BRAF mutation, how are you ever gonna how do you know which one is better? The short answer is basically we don't know, right? So there's really no systematic data to really, compare. We all know that we shouldn't do cross-trial comparisons. So how do we choose? It's certainly, a discussion every time. I feel like in my clinic, somebody comes in. I think it's also, I think you already probably discussed about when to check for BRAF status early on, and there's very practical considerations. And I think there's also that our clinic is a little bit impacted by the availability of BRAF status, because oftentimes when a patient comes back with a positive sentinel lymph node biopsy, the BRAF status is actually not available, and then sometimes just out of convenience, okay, let's just start nivolumab. I know that this is definitely happening in clinical practice. So there's certainly this question well, one should really emphasize that that's one argument to actually really pursue BRAF status early on. But there's other difference between the regimens, right? I mean, I think an important one is certainly the toxicity, right? The toxicity is very different between nivolumab and the trametinib, and they both have sort of pros and cons, right? So the overall, I think everybody who treats with immunotherapy would probably agree that Nivo is generally a well-tolerated drug. So most patients, just go to the treatment and they actually have fairly normal life. But when there is a grade 3 or higher toxicity, it's actually pretty significant, right? And there's the overwhelming majority of patients are doing really well, but some of them really land in the hospital or are stuck with, say, thyroiditis for the rest of their lives, right? And so that's reflected in the data here, where you have low percentages of patients who are discontinued from the treatment with nivolumab, 7.7%. That's in striking contrast to the trametinib, where it's really a lot more challenging to actually keep a patient on the dose. A lot of patients get fevers and chills, and they just can't tolerate the standard doses, leading to dose reductions of more than half of the patients. And 26% of the patients actually never complete the regimen. All that being said, I would still say, and I thought just throw that out there because I know that this is being discussed in the clinic a lot. And you could have the perspective and say it really doesn't matter whether you have 26% of patients that have to stop, because that was actually, so if as long as they get the treatment for some time, they were still included in the study. And so the data, you would think like the data actually doesn't change, right? Because those same issues happen on the study. So it's not like, so the fact that 26% of the patients could not complete the course does not mean that it absolutely doesn't work in those patients, right? So we don't really know how long you have to give the dabrafenib. Maybe you have to just give it for like 2 months, and that's fine, right? So I think it's not like the most compelling argument to say you can complete the course because, well, we have the data with this sort of compromise. But anyway, it can also be, difficult. Just the management is just a little difficult sometimes, and the patients are obviously symptomatic, and it's not pleasant. And since it's so many, it can be relevant. Of course, like we always say, like don't compare. I just wanted to point out here what I said before and just put it on a slide. When you just want to say like, okay, dabrafenib hazard ratio 0.47 for recurrence-free survival, hazard rate 0.57 for survival. How does that compare to nivo, right? So how does nivo compare to placebo? And when you try to actually compare the nivolumab against the placebo, one way to approach it would be to actually overlap it with, or to overlay the curves with the data from the ipilimumab, your RTC study, where we actually have a placebo arm. And then just look at how it sort of spreads out. And what do you see here? The IPI data are much more mature, right? So that's why the curves go out a lot longer. But you can see that when you look at the red curve is the placebo, the blue and green in the middle are the ipilimumab in both studies. So I think what's nice here is that you can see that they're actually pretty close together. And then, if you with a caveat of cross-trial comparison, you can see that the nivolumab against the placebo is actually quite striking, right? So it's probably more than, it's like 25% at 18 months or so. It's just sort of as an exercise, how do these treatments compare? Probably the more relevant comparison is if you actually try to compare the dabrafenib and the nivolumab, right? And here it becomes a little bit more complicated because one has a placebo arm, right? The dabrafenib is placebo versus IPI. But just, when you look at the curves, one thing you can quickly see is that there is this drop-off with nivolumab early on, right, that you don't have with the dabrafenib and trametinib. Why is that? Well, that's because the drugs are working quicker, and there is fewer patients who have a very early recurrence. And then, so you could see instead that there's probably some patients who are just like don't benefit as much from the nivolumab because their disease is like more aggressive. Problem is, of course, you don't necessarily know that. At least we don't have yet really good data. I mean, you sort of know, but you don't know it. You can come up with like a likelihood, a patient who has like a higher risk, but you still don't know it on an individual patient basis. One other thing is like, well, we were talking about plateau. I do think you could, if you really believe in immunotherapy, maybe there is actually an earlier plateau here compared to the target therapy, right? When you look at those upper blue curves. Just throwing that out there as well. So in summary, this comparison between those two options, the arguments that would speak for using the nivo and also by extension the pembrolizumab, this plateau that I mentioned, it's overall, better tolerated in patients. It's easy and reliable administration, right? It's IV, the patient is definitely get it. It's an argument for maybe a non-compliant patient, for sure. And I think that's actually, study patients are typically more reliable patients. And, maybe you have like somebody who you think like they're just not going to take the drug or they can't even understand. That would certainly be an argument for an IV drug, right? And then there's like this concern that I've actually I didn't go into great detail, but with a target therapy in patients that are potentially curable, there is this issue, well, potentially there's like secondary cancers with the targeted drugs, right? Because there's paradoxic MAP kinase pathway activation. We have seen secondary cancer, skin cancers with, particularly with BRAF monotherapy. And we really don't have long-term data with any of these drugs yet, right? So I think it's at least possible that maybe sometime in the future it may be a problem for some of these patients. What are the arguments for dabrafenib plus trametinib? There's really no life-threatening toxicity, right? So it's really unlikely that somebody will die from these treatments. And then I think there's this more maybe theoretical idea. I try to get it a little bit on that, on when you look at the Kaplan-Meier curves. But there's this notion there that with the targeted therapy, the resistance issues that we have may be more relevant when there's a larger tumor burden. Well, we'll actually discuss this in the metastatic session too. We now have data that the lower tumor burden patients definitely do a lot better with targeted therapy. So there's this notion that potentially the target therapy, when there is like really minimal disease burden, may be able to really truly eradicate all the tumor cells as opposed to the metastatic setting. So that would be sort of a theoretical argument for using the target therapies. How am I doing in time?
You're doing fine.
How much?
Go on.
In the middle, roughly?
We have time.
Just wanna, okay. 9 minutes? Oh, okay.
No.
So it's like, okay. So those were the standard. And I do want to point out, like, what I'm going to discuss now is not standard of care. And certainly, I'm not saying it's never been used or it's never used in the US, but it's not like we are treating everybody with neoadjuvant therapy now because we have some data. This is from a presentation that Alexander Mendez gave at ASCO earlier this year, just to make the point. Oh, there you go. I got it right here. Okay. Really to make the point, well, we're doing reasonably well, and that looks all great, like 13% improvement with the nivolumab. But the bottom line is also like, half of the patients, almost half of the patients at like 3 years, when you roughly look at the target on the left side and the nivolumab of patients who have like the higher risk, right? Like stage 3, clinically evident lymph node metastasis, they have a recurrence, right? And so the adjuvant therapy improves outcome, but it certainly there's a substantial number of patients who are still not helped by these therapies. And so this obviously the neoadjuvant therapy focuses on those clinically evident melanoma disease patients, right? So it's very different from what we had in the earlier talk. This is not obviously a sentinel lymph node positive patient. Those are patients that have clinically evident palpable lymph nodes, typically disease at the time of presentation. So, and the question here is like, oops, and actually, just wanted to make this point. It has this interesting retrospective review by Axel Hausschild, where he took the data from the dabrafenib, is it? Yeah. Yes, the dabrafenib, and basically looked at the new staging categories, right? So in the AJCC in the 8th edition, we all know that stage 3A is really like a much better prognosis population. And so you can see on the left side with the traditional one, there's definitely already like sort of a hint that the curves separate out more clearly in the higher risk patients. So presumably those patients getting more benefit from the adjuvant therapy. And that difference is even more striking when you apply the new classification, where when in particular the patient with stage 3D melanoma have really a striking difference. So more disease, more benefit from adjuvant therapy. Okay. Looking at what's already been done, I think the bottom line is it's small trials, small patient numbers. There's two studies that were published with dabrafenib trametinib, and there's 4 studies that have been published using mostly ipilimumab and nivolumab, some of them randomized to ipilimumab plus nivolumab versus nivolumab alone. You can look for yourself here. And the point here is really more to sort of show what the numbers are, right? So those studies are. Is this better? Okay. All the studies that I showed you before were hundreds of patients in each arm. Those are 20 patient studies, most of them. But like I said, so 2 studies on dabrafenib, 4 immunotherapy studies. I wanted to go in a little bit more detail on those 4 here. There's just to look at what has been done. It's actually really kind of all over the place. Some common themes are obviously giving the treatment. You have a patient with clinically evident disease. You give them the immunotherapy or the target therapy for some time. Then you do surgery. And then most of the studies actually, except for the one that Christian Blank did in the Netherlands, did then the adjuvant therapy sort of fairly standard for a year. But you can see there's really substantial differences here in the time that the adjuvant the neoadjuvant treatment is given, which is shown in yellow. It goes from 3 to 12 weeks, and that obviously can have really striking implications, as we will discuss. And so this is the general design of these studies. You basically have the pre-treatment, and you have this really valuable surgical resection specimen when you do the pathology. So really from a scientific perspective and something to learn about immunotherapies and about targeted therapies, those studies are incredibly valuable, right? So that you're not going to have any other study design where you do a treatment and then you have a large biopsy specimen where you can do multiple analyses and really learn from these treatments. Now, I would say one important take home from these studies is really what you can learn. Just forget like adjuvant therapy, just what we can learn what these immunotherapies or the target therapies can do. And I just want to focus for like a minute or two on those results and then get back to the more clinically relevant data. So there's the one study that I wanted to talk about is with BRAF/MEK inhibition. It was actually 14 patients that were treated. And this study had a little bit of an odd design. They had this randomization 2-to-1 where the comparator arm was basically standard of care adjuvant therapy. But the study was actually started in 2014. And the standard of care was basically, for most patients, not even the modern therapy. So it's really actually not, so kind of forget about the standard arm. It's really, we should focus on the arm where the patients got the dabrafenib. And I want to make like 3 points here. The first point is what you can see on the left side. Most patients, as expected, had deep responses, right? So you look at a waterfall plot, you look at the radiographic response on the upper panel of those patients. What did the scans prior to the surgery show? You can see, like when you look at on the lower left panel, you see the pathology response, right? So you see what the pathologist sees under the microscope after these treatments. You can see that there's actually quite a bit of a, it definitely doesn't, it's not entirely consistent, right? So the patient with a complete responses versus partial response between radiology and pathology is not the same. And then you can, probably most importantly, in the middle, you see the outcomes. So the patients who had the neoadjuvant, so you see that, so the neoadjuvant is in blue, and the patients who had path CRs are in green. And that's the curve that basically is like at 100%, right? So that's an important first thing. So patients who had a complete response, majority of those are doing really well. And then on the right side is a finding, just to make the point that target therapy can actually have an impact on the immune response, which you can see that, so that it's basically paired samples here. We're looking at patients that had a pathologic CR versus not, and you can see that, or you maybe cannot see, but basically you look at green, red, indicating that there's like a change in the immune infiltration by looked at RNA analysis. And that's not quite as striking in the patients who didn't have a path response. Okay, so in summary for this study, as you would expect, radiographic responses, path responses, there's an association between the path response in particular and clinical outcome. This study here is coming out of the University of Pennsylvania, where they treated 30 patients with nivolumab for 3 weeks, and then surgery, and then a year of nivolumab. So fairly standard adjuvant therapy, but a short course of neoadjuvant PD-1 inhibition. And they had 8 patients who had either a complete path response or a partial. And they're looking here at the differences in outcomes between those patients. So when you look in the middle, we're looking at the disease-free survival in patients who had either viable tumor or not viable tumor, so viable in blue, and basically everybody who had no viable tumor, so less than 10% had not recurred, versus patients who had viable tumor was a much higher likelihood for recurrence. And then also really interesting, patients who had lymphocyte infiltration shown in blue, so brisk, had much better disease-free survival compared to the one where there's no lymphocyte infiltration. And you can also see that in the panel on the right lower, where the ones in red there are the ones that have non-brisk tumor infiltration, and they're the ones where they have basically 90 to 100% tumor still there, and the patients who have tumor infiltration have like a lot more tumor. None of the patients who had the PCRs have recurred. So this study, it's hard to say whether the nivolumab actually did anything in the neoadjuvant setting, but it's like a remarkable biomarker, basically knowing. So if you have nivolumab for 3 weeks and you have a path CR and you have lymphocytes in there, that's essentially, probably shouldn't say the word cure, but there's a very high likelihood that when you then get the course of nivolumab, you will have like a really good outcome. So you can definitely say that from that study. Okay, this is a study. Here I just want to, since I'm like over time now, I just want to make a couple of points. So one is that this study used PD-1 inhibition alone versus ipi-nivo. And they used the PD-1 inhibition for 12 weeks in that study. And that was probably too long because there were 2 patients who actually could no longer undergo surgery because they had progressed. And that's obviously a reflection of the PD-1 inhibition having a lower response rate, which you can see on that graphs on the left side. So I think the take home here is for immunotherapy, you probably need to use the regimen that has a higher response rate, which is ipi-nivo. On the right side, you see data that are comparable to what I showed you in the prior study, where they looked at that it's T cell receptor sequencing. They looked at clonality of T cells in the peripheral blood, in the tumor, and basically there's not a clear association, but that there's generally a trend when there's more clones that are specific for the so more clones that are seen in the tumor that then expand in the periphery, there's better outcome. And I'm not going to go into all the details there, but it's certainly an interesting analysis where you basically have evidence for tumor recognition by TCR sequencing. You see that those clones in the peripheral blood, and those patients who have more clones or more expansion of those clones are the ones who are generally doing better. And last but not least, out of these neoadjuvant studies is Christian Blank's work with ipi-nivo, where they also looked at clones here, as I said. So you can forget about the left side, but that's basically just looking at outcomes with neoadjuvant versus adjuvant, but those are low numbers. On the right side, you can see in blue are the patients who had adjuvant therapy, and on the right are patients who had neoadjuvant therapy, and you can see more expansion of these clones that are presumably specific for the tumor. Which is also just an interesting observation and may argue for the neoadjuvant therapy, basically. And sort of what do you do? You give the immunotherapy while there's a lot of tumor still in place, and then that may actually make, in terms of the biology of the treatment, make a difference. Okay, so those are correlative analyses. Let's just spend a minute on what are sort of so far the clinical outcomes. Here you have all the 6 studies. We're looking at path CR rates again. The two study with a target therapy are in the 50-60% range. Generally, with ipi-nivo is more on the order of 40-50% with some exception, and the nivo is really low. But this is like that's the key information here. How many patients get a pathologic complete response? I just wanted to point that out. And you can actually already see when in terms of the clinical outcome, so the first 2 studies are targeted, and the last 4 are immunotherapy. For all of those 4 with immunotherapy, actually, there's no median or recurrence-free survivals yet available because there hadn't been enough patients who had recurred. Okay, let's look at the recurrence-free survival by stage and drug class with immunotherapy versus targeted therapy. And this is not really like, you cannot really, it's not a randomized study, but it gives you a glance at like how does immunotherapy compare with targeted therapy. And I would argue there's a clear difference, right? Immunotherapy, and this is generally like, this is all comers, seem to be doing better. And that's like true for stage 3B and stage 3C. When you actually look at the patients who had the path CRs, which, as I pointed out, are roughly half of the patients, when you look between both for immunotherapy and target therapy, those patients doing a lot better, as I point out. But when you look, so it's basically 88% on the right side versus 43% 12-month recurrent-free survival in these patients. If you see that path CR versus you don't see it, for immunotherapy, it's 100%, right? 100% versus 72%. Oops. And so that's basically, I think the key take home from the neoadjuvant is like, path CR is like incredibly important. It really tells us about the mechanism of action of these drugs. And I do think it's an argument if you have that decision between targeted and immunotherapy, for even now, like where we're not using the neoadjuvant yet, but it may actually also argue for immunotherapy in the adjuvant setting. Oops. And so just as a summary here, as I pointed out, systemic therapy is really the standard of care for all stage 3. Actually, I didn't go into some of the nuances in the United States. I would say it's actually fair to say that even the stage 3A patients are, so it's approved for everybody, but there's definitely some arguments you could make how reasonable that is. So stage 3A patients, how much they actually benefit is not really clear. But the bottom line is it's approved for everybody and most patients probably get it. And I'm happy to hear from you guys when we discuss like what the practice is here. There's no clear preference between the two. The neoadjuvant we really just discussed that the PCRs and the path CR is really important, and just this I think incredibly interesting statement is like that basically no patients with a pathologic CR from immunotherapy has recurred to date in these neoadjuvant studies. All right, I'll stop here.